right. Everybody, this is Molly Cripe Birt. I'm the host of this lecture. So I just want to remind everybody to mute up until the very end. That way, I don't get distracted because I'm pretty good at ignoring people coming in and out of a room, but I have yet to figure out how to ignore Zoom information now that we're all virtual. So I will get started here in a couple of minutes, 1 minute by my estimation. But why don't everybody direct their attention towards the chat, and that's accessed down at the bottom of the screen. There's some controls. It appears that we've got people that have already been chatting, which is great. Up at the very top, I have inserted a link by request, and people have asked for handouts. What I have included into that link to a Google Drive are 3 documents. The first is a paper on how to write a paper, which I realized after writing it, the last thing y'all want to do is read a formal paper about how to write a paper. So then I've also included a PDF of the slides, so it'll be a much more succinct version of that. I would say that my paper is pretty fantastic, but for your sanity, the PowerPoint slides are attached. And finally, there is a link to an already published case report that I wrote. It was published in the Modern Equine Vet in, I believe, April of 2020, which means that it went through the whole process of what we're talking about tonight. It was part of an application that was accepted with my VTS application. And then I went on to submit it for publication this past spring, and it was published then. So it's not like you're going to be stealing my work if you see it. But I figured that since it's public, it's a public publication, that you guys might find it useful. Let's see, somebody's asking to repost the links. Here we go. It's tinyurl.com/some numbers. So again, if you're just joining us, mute your phones. I'm highly excitable. I might get distracted. And while I'm getting kind of set up here, why don't you guys go ahead, check out that tinyurl. And then also do me a favor and post your like VTS that you're interested in. This talk was originally intended for folks who are applying towards my academy, which is the Academy of Equine Veterinary Nursing Technicians. And it's quickly grown in popularity. So I'm kind of curious to know where you guys are coming from. There we go. Let's see here. I apologize. Some days I think I have Zoom figured out. Sometimes I don't. Well, all right. So since I don't have a moderator helping me out with this one, I would love it if you guys would save your questions for the very end. of the presentation, meaning like if you want to verbally speak those questions. But if something pops up into your mind, if you throw the question in the chat, once this is all done, I will be able to see that and we can redirect the questions there. I do intend on having an open discussion at the end, time allowing. So if you can save it, and then, yeah. I guess welcome to how to write a case report for submission to VTS Academy, which is a very long way of saying, let's deconstruct something that can be really frustrating for applicants towards the VTS Academy. My name is Molly Cripe Birt. I have a bachelor's degree in veterinary technology from Purdue University. I have been working at Purdue University since my graduation in 2008. I moved into the large animal surgery technologist position in 2012 after years of working as like a med surg technician and on kind of a critical care nursing position since my start. And in 2015, I applied for my VTS-EVN in the Academy of Equine Veterinary Nursing Technicians. So I'm not exactly a baby when it comes to being a VTS, but by all means, I recognize that there are people who have been VTSs in all academies for far longer than I've had a career. So what I am intending to say is that I really do enjoy writing. I figured that I could share my insight on this, but in no way, shape, or form should I act as a complete expert on this. My email will be at the very end of this presentation. I would ask that all hundreds of you not email me and expect a reply immediately. I have a pretty busy schedule working full-time at Purdue and also acting as the president of the AEVNT. So save your questions for the end. If you have further questions, you can reach me on Facebook, either through the AEVNT's Facebook page or reaching out to me on Facebook. And if you want to see pictures of my very boring life, you can check me out on Instagram as well. I do more than just kiss horses on the face, although that is one of my favorite hobbies to do. So just as a disclaimer, I am pretty adamant about this. You as an applicant absolutely must adhere to the standards of your own VTS Academy. Let's go ahead and so when you are applying for this VTS Academy, there are going to be expectations and guidelines that are specific to the academy that you're applying for. I'm not talking specifically today about my academy's standards and expectations. This is a very broad presentation, which means that if you have something very specific that you have in terms of questions, please do seek advice from the mentor that you have been assigned to through the applications committee at your academy, or if the mentor situation isn't working for you, reach out directly to the applications committee. I can't speak on behalf of anything other than the AEVNT. So we're going to leave specifics aside. And one thing that I have found most amusing is one of my colleagues that has a VTS in internal medicine cardiology, is that she tells future applicants that they need to date their VTS application. They need to take it out to dinner. They need to buy it wine and flowers. They need to go to bed with it at night. They need to wake up with it in the morning, and they need to make it breakfast. Like, if you don't know your VTS application front and back to that level of intimacy, you need to get there. There is nothing that I can do in this presentation that can replace that level of understanding. All right. So unfortunately, writing for our case logs can feel a lot like people are expecting us to be Ernest Hemingway, right? That would be the author that's looking very poignant while typing on his typewriter. The reality is that we feel mostly like myself here, where I had to report to my colleagues that I ate all of their Kit Kats during second shift. But we do often feel a little overwhelmed. I recognize that most of us do not have a background in an English degree. We are not considered novelists. We feel like we have to be novelists. And so what I'm trying to deconstruct here is to first flip the narrative. When you go to write your case report, when you go to do some research on your case report, instead of saying, I have to do this thing, Instead, try saying, I get to. You get to talk about your favorite cases. You get to choose the topics that you care about. You get to show off your knowledge and your skills. You get to be the expert. The whole point of you guys going on to further your career by becoming a VTS is to become experts in your field. So if you consider that you are writing an application to be considered an expert in the field, you should already have the confidence of somebody who is an expert. And what's really cool about a case report is that you get to talk about the things that you really love. You get to select the cases that really lit a fire under you. You get to talk about the cases that you were really involved with, and you get to speak from a position of authority about that case. So instead of saying it's a chore, instead of saying, oh my God, I got to do this thing, try saying, I get to be the best version of my professional self.
The authentication says this. So this is what one of these hearts feel.
Let's go ahead and mute. Thank you.
No paper, no money.
All right. So we're first going to talk about the purpose and intention of a case report. Then we're going to discuss the organization and the content. That's the meat and potatoes of your case report. And then a wee little bit about tips and tricks that I found have been very useful, but also that'll be a time that we can open things up for discussion. So the whole purpose of a case report is to showcase the in-depth knowledge that you are required to have as a VTS. So in this case report, you present the details of the case as it's presented to your clinic, the treatments that you guys have done and performed, and the overall outcome of that case. And it professionally describes the involvement that you have had personally in that case. Simply put, case reports are medical stories. They're similar to the ward rounds that you would experience either back in school, through internships, and maybe, and hopefully your practice still does ward rounds. And the only picture I had of ward rounds is actually Dr. Stacy Tinkler taking our vet students out in a sunny patch this past fall and socially distanced, doing ward rounds in that scenario. All case reports really need to be written in a logical, chronological order. You need not skip around. Things should be presented as they happened and then wrapped up neatly throughout that case report and for one final end. So a bigger goal that you can consider, I mentioned this at the very beginning, is that you can use a case report to relay clinical experience to other technicians that you work with. They can be published, and that's allowing for you to disseminate your knowledge to the rest of your colleagues in as technicians in a journal setting. You can teach nursing management in this way. On some regards, a case report, particularly for our veterinarian colleagues, the case reports are used to highlight obscure and odd case presentations, and we'll kind of put a pin in that and circle around to it here in a minute.
You're not that adventurous. Yes, I am.
Hey guys, let's mute.
Okay. I'll do it. Let's all do it. I'm in. This is crazy.
Thank you. I just want to remind everybody, I don't have the capability of muting all of you, so if you can take it upon yourselves to remain muted, that'd be very helpful. Finally, this is also a way to describe novel treatment options that are performed in the clinic. Now, the last two are really reserved for veterinarians because they're the ones that are going to be prescribing the treatments, discovering these weird new ways of performing something, as well as highlighting kind of the odd case management that they'll see. So organization, we're going to break it down through case selection, the collection of information, and how to recruit support to help you guys out. This photo is of me mostly raising my eyebrows at the particular case, not necessarily at the task at hand. I wanted to clarify that. This horse was allowing me to use every part of my VTS-EVN professional career based on all of the weird situations that that horse had had. So in terms of case selection, I had mentioned that case reports are a great way to highlight weird presentations, obscure cases. The problem though is that we don't want them to be so complex that you can't fit the requirements of your case report in the standards set forth by your VTS Academy. What you really want to do is to be able to select a complex case that is relevant and applicable to your career, and specifically towards that VTS Academy. You want to be able to showcase a variety of technical skills that you used specific to that case. And you want to feel confident enough in your knowledge that you'll be able to discuss the treatment plan that was implemented, as well as the application of your nursing plan. Again, consider this an exhibition of your professional portfolio and something that you're excited and passionate about. When I say your professional portfolio, is trying to figure out a clever way of saying, you want to be able to say about your case reports as a whole, this is who I am as a technician who is applying towards a VTS Academy. I can do these kinds of cases, this kind of case, etc., with these technical skills. And then to be able to demonstrate that knowledge. That is how you should approach on the cases that you select. Now, I mentioned avoiding like really obscure and odd cases. Those cases, the ones who are really arduous, the ones who have been there for a very long time or have had such an extreme amount of treatment that it would be difficult for you to piece together all of its information in a certain word count or a certain page count that is needed. Those cases, while I'm sure are the best examples of you being a VTS applicant, those are not the cases that you want to report on because the details become so complicated. You also want to avoid repetitive cases. And what I mean by that is, as a technician working in an equine practice, I see lameness exams all day, every day, and I don't want to call them boring, but they can be very boring and they're very repetitive. That is not an opportunity for me to underscore just how much I know about the subject matter at hand. We really want to avoid using cases who we didn't get to participate in as much as we would have liked. We do not want to write about a case report where we didn't get to utilize our technical skills. And on that note, if you are writing about a case report stating that you did technical skills on your advanced skills list that you don't have signed off, that is a no-go. Get those advanced skills signed off or don't use the case that you have. I know that there are certain academies that require a certain amount or a certain percentage of those advanced skills being demonstrated in your case reports. Can't speak on that on a personal level, but you need to pay close attention to that. One of the biggest concerns that we have for the AEVNT is when we have applicants who say they have done a certain task in their case report, but then when we go and look back on their advanced skills list, it's not been signed off. It just doesn't work like that. So for example, just to like kind of break it down for you, I have hundreds of cases that I could have chosen from, and some of them are listed here, not all of them. What I chose to do did not necessarily reflect what I wanted to do. For example, this little foal that's featured here had a complex comminuted fracture that ultimately ended up being open and became a non-healing, non-union fracture. And I thought, well, I have been involved with his case so much that this is literally, you know, the portfolio of myself that I want to portray. The problem though is that he was hospitalized for over a year with us. That is the very definition of arduous. So as far as lameness exams went, I wanted to keep out the routine lameness exam. Okay, it's boring, right? But my complicated lameness exam, the fracture, was not something that I wanted to be, it was not something that I could physically write about. Instead, I kept with something that was middle of the road. I know that I needed to, based on the AEVNT's requirements and all of the fields in which we specialize in, I know that I needed to have at least one anesthesia case. I wanted to have a neonatal case because they're so common and important in equine medicine. But if it was in the NICU, again, that case was going to be way too complicated for us and for me to write about. On the other hand, I did have a neonatal case that came in for a minor surgical procedure that ended up being more complicated and having several different issues that arose during its time here. So I did choose that case. Then we had some medicine cases. And even as a surgery technologist, I wanted to make sure that I had some medicine cases on my roster. So I chose a botulism case and also a case that ended up coming in originally for poor performance and was diagnosed with bronchial hemiplegia, which was surgically corrected. Finally, I wanted to highlight my critical care skills. And so that's when I chose this colic case. If everybody could make sure that they're muted, that'd be great. Thank you. So this colic case is actually one that we're going to talk about today. I'm going to use as multiple examples. Again, this is the one that was published in the Modern Equine Vet, and it's the one that you guys have a hard copy to. All right. So moving on to the organization of information. At the very beginning, you have to start by collecting all information first. So you need the presenting information, you need all the diagnostic reports, the surgery reports, the blood work results, the treatment plans, and the visit summary. Then you have to store them in a single safe location. I cannot emphasize this enough. You have to respect your client, patient, veterinarian confidentiality, whatever you choose to do, however you choose to do it. For me, I saved those medical records as a PDF, and you can see in the image that I have them all saved here. Whoop. I have them all saved in this folder that's labeled medical records. If you print them off, you need to make sure that they are not leaving the hospital. The reason for that is that if you happen to lose them, then your client's information is out there in the world. There have been technicians who have reported staying late for after their shift to work on their case reports, and then getting pulled back into work. What I would end up doing is finding a quiet location where nobody would know where I was at after I left work and then came back. So that was kind of my trick to not getting pulled into stuff. And that was how I managed to save these medical records, keep them on site in our hospital, not take them home, and could go through them and organize them appropriately. What I would recommend is over preparing. You'll hear me say this multiple times. If you get all of the medical record information in front of you, you can go through and find the important information. Take a highlighter to your PDF, highlight all of the important information, flag it, tag it, and then you can start organizing it in a way that makes sense. And then once you get all of it in front of you, then you can start to say, okay, this part doesn't matter, this part doesn't matter. And then you shrink that medical record down sizably, and then you can start the writing process from there. What you want to do, what I recommend to everybody is to find an editor. Recruit a little team of support for you, if you will. A friend, a family member, or a colleague. They will look for grammatical errors. They will look for spelling mistakes. They will look at sentence structure. They will look for clarity and brevity. If you're my friend, you'll realize that I have a tendency to go on a bit. And so I rely heavily on the people to make sure that I'm not making stuff up. I'm not making a mountain out of a molehill, if you will. What would be great, like it's great if your dad wants to help you read your case reports, especially if he's great at grammar and spelling and the English language. That's fantastic. But what's even better is if you can get your veterinarian, a resident who you have a really close relationship with, a veterinary technician, coworker, particularly one with a lot of experience, to be your content expert, if you will, because your content has to be factual, right? And I'm not saying that we don't know what we're talking about, but I think it's a very easy, especially when you're dealing with the magnitude of a case report, to get your wires crossed. You want to make sure that what you're presenting is sound veterinary medical information that is reported properly, and that your dosages, your units of measure line up. You want to make sure that you have the modern, most up-to-date veterinary information possible. And you need to make sure that your pathophysiology and disease processes are accurate. It's very easy to get your wires crossed as we go throughout our careers. And finally, make sure that you're referencing books and journals. Some academies want there to be references, like an actual bibliography at the end of your case report. And if that's the case, then you need to have your references available to you. Oh, and also just as a note to this image that's posted here, this is actually an article. My friend and colleague, Dr. Sandy Taylor, bled all over this, and I did not go home and cry at night. I was so grateful that she took the time to bleed all over my my draft for this article, because it meant that somebody trusted me enough and believed in me enough that they would take the time to do that. And so instead of crying, I went and bought her a bottle of wine as a thank you. So if you try to not get frustrated when you get your edits back, instead be grateful that somebody cares enough to make sure that your work is as perfect as they want you to be and that they think you are. Also, just take a look at this. We'll go back to that other image that I had showed you. This case report that is circled here, that's 4 edits before I was done. 4. I went from over 20 pages for this particular case down to the required page count. There was a lot of stuff I cut out. So it can be done, and just kind of giving you guys a reference, just how much work can be done to cut them down into a proper length, and to not get frustrated if you have to keep going back to it. So when I say the proper use of the English language, I fully recognize that we all have jargon that we talk in as veterinary medical professionals, but what we want to have is a formal presentation. So I'm being pretty casual with you guys right now, but if I were standing up and talking about a case report, I'd kind of change my tone a little bit. We want to avoid contractions. So a contraction is if you take the word cannot and say can't, or are not and say aren't. What you want to do by doing that, by avoiding contractions, you sound more formal, and it's taken that much more seriously. You also want to avoid superfluous language, flowery language. That's why I said superfluous instead of flowery. You want to avoid that level of talk. It just ends up gumming up your work, and it doesn't add to your case report. Along those lines, you want to avoid until necessary. So whatever your academy requires of you, saying I, we, like I did this, we did that. Instead, you can say it was decided, the owner determined, the veterinarian diagnosed, the veterinary team treated in this way. By having that third-party perspective in your writing, it makes it that much more formal. Pay close attention to spelling and grammar and sentence structure. I'm going to repeat that about 1,000 times. It's frustrating when I see applicants submit case reports who are so qualified, but didn't have enough time or enough forethought to go back and double check their spelling to ensure that their grammar was appropriate. And I'm not talking about an Oxford comma, like that's a hill I'll die on, but that doesn't matter. What I'm saying is that if a sentence is 3 paragraphs long, that's bad grammar, and it makes very little sense. Alternatively, we want to avoid writing out our sentences without a noun, a verb, and the content of that sentence. So I've seen sentences where it just says creatinine kinase 200 and whatever the units were. And there was, so it just was like basically taking the bullets out of a list and then making them into sentences, but not actually making it a sentence, if that makes sense. Also, you want to spell out all of the acronyms initially. While we all assume that the person next to us is as smart as we are, we don't want to actually make that assumption about ourselves and about the people who are reading these case reports. So for example, I have highlighted here, post-operative ileus. I spelled it out initially, and then I indicated that it would now be referred to as POI in parentheses behind it. Then below, wrote it out as lidocaine is commonly used drug for POI. And so whoever was reading this case report would know that I'm now referring to POI as post-operative ileus. The same thing goes for breaths per minute, mucous membranes, capillary refill time, packed cell volume, on and on and on. The list is endless, but where your case logs, you may be able to write out all of those acronyms as a sheet before the case logs happen. You want to make sure that you're defining in every case report those acronyms. So your units of measure absolutely must be on here. So just as a general baseline, your 5 rights include the drug name, the drug dose, which could be milligrams per kilogram, international units per kilogram, etc. It could be the drug amount, so milligrams, international units, milliliters, etc. The drug route, IV, IM, sub-Q, etc., and then the frequency that those drugs are given. So over in the example I have, the fluid rate was being delivered at 2.5 to 3 times maintenance, or 150 to 180 mils per kg per day. Also, there was a loading dose given of 1.3 mg per kg, or 41 mLs, 2% lidocaine, that was given intravenously over 15 minutes, followed by the milligrams per kilogram per minute, or 94 mils per hour. If that's not in there, there's going to be some questions. So if it's listed in the medical record, potassium penicillin, 22,000 international kilograms, with, that large number of international units, IV QID, you would write that in a sentence. She was given 22,000 international units per kilogram of 13,728,000 international units of potassium penicillin intravenously every 6 hours. And of course, you can play with the sentence structure with however you want that to come across in your report. The units for blood work need to be reported every single time you, pardon me. Oh, my apologies. Thought my sinus was going to come out there. Anyway, so you want to use the units for the blood work every single time that the blood work is reported, not just the first time. So PCV, 52%, total protein, 8 grams per deciliter, and then the lactate, obviously 4.5 millimoles per liter, whatever it is that you're reporting. Make sure that those units are there every single time. We really want to avoid the use of jargon or slang. We say ADR all the time. Like the receptionist calls and says, hey, there's a calf coming in, it's ADR. Like, I know what that means. But again, this is a formal case report. And so using the power of your words, of the observations that you see with your patient, you can expand a little bit on the concept of ADR. And I think that that's very important for us to recognize. We're going from being technicians to being a VTS, and this is one way to do it. And then obviously when you're writing, there's going to be the logical progression, the chronologic flow of the paper. Not to be glib, but literally a case report has a beginning, a middle, and an end. That's it. It's a medical story, if you will. To break it down a little bit further though, we have in our construction that is absolutely necessary to include in a case report is the signalment and history, the examination findings upon presentation, the diagnostic workup and the findings, our treatment plan, and the progression of that treatment and the status changes of the patient. Finally, concluding on the outcome. If your academy requires it, a discussion at the very end. Like most stories, well, I take it back. I like to read chapter books, but you get my point. Most stories do not require headings or changes in this. So you don't need to write in your case report unless indicated by your academy. This is the signalment in history, and then write your case report there, and then examination findings as a heading, and then the examination findings. It's literally just a story. So signalment in history, pretty straightforward. We're looking at the age of the animal, the sex, the breed, and the species, its color, its weight. Please be mindful of confidentiality. The reason I say this is you don't want to use the patient's name in your case report. Instead, what you could do is come up with a pseudonym. Your VTS Academy may have a different standard, like assigning it a number. The case report that I gave you guys should have just the patient as she or the patient. Included in the signalment in history is the date of presentation, and you're going to report the relevant case history. So it doesn't matter if Fluffy got its nails trimmed 3 days ago, unless it's presenting for a broken nail or, you know, bleeding from the quick, something like that. Multiple presentations do need to be briefly summarized. So if you have seen this case multiple times, or this case is presented to your practice multiple times in the past month or so, you can briefly summarize it, but there's no need to go into an extraordinary history in that way. So what we could say about the case that we're following today is that a 13-year-old chestnut paint mare weighing 624 kilograms presented to Purdue University Large Animal Hospital for a colic lasting 12 hours. Although she had a stoic attitude, her general appearance indicated that she had been rolling. Brief and to the point. Then we look at examination findings upon initial presentation. So report those in a systematic fashion, just in the same way that you would perform a physical exam. You want to literally report it in the same way. So report the vital signs, report your auscultation findings, and your visual assessment. If palpation is part of the examination, include that as well. So for our colic case, I had wrote, she had a rectal temperature of 101.7 degrees Fahrenheit. Her heart rate was initially 40 beats per minute, but elevated to 93 beats per minute. From there, the initial diagnostic workup and findings can be reported. In this particular case, it was an emergency, so things moved pretty quickly. And we can then describe those diagnostic tests that are performed. So that includes everything from clinical pathology, microbiology, ultrasonography, radiographic results, more advanced imaging, serologic, pathologic, immunologic, and endocrinologic tests. In the case of our colic, it literally is just reported amongst many, many things. But in this instance, I wrote, an abdominocentesis was performed and the peritoneal fluid lactate was 8.3 millimoles per liter and the total protein 5.4 grams per deciliter, which was consistent with bowel ischemia, necrosis, and tissue devitalization. Interpret and assess those findings. This is how you take a case report and level it up for being a VTS. By saying that these were the results and that is consistent with bowel ischemia, necrosis, and tissue devitalization, I am showcasing my knowledge. But what I really want to caution you guys with is how you word what you're writing, because again, we are not veterinarians. We need to respect our state practice acts. We need to respect our role as technicians. So oftentimes in the case report, I would use a very passive language, like what I have here. Hey guys, we need to mute. We're gonna play a little game. Like if you guys are drinking at home, shot every time I have to say that. Thank you for being patient. So what I ended up saying in this terms is it's not my role to determine that the horse has dead intestines inside and they need to come out. It is my role to say these values indicate that there is bowel ischemia, necrosis, and tissue devitalization. And therefore, I know to then move on to the next treatment plan. We can then reveal the diagnosis made by the veterinarian based on those diagnostic findings. So for our colic, I wrote, due to abnormal rectal and ultrasound findings with unstable vitals, the attending veterinarian recommended abdominal exploratory surgery. Short and sweet and to the point. From there, you can make a treatment plan with a complete listing detailed. So all drugs, all fluids, all the procedures that were performed, any application of bandages or casts, on and on. You guys know your patients best. You know the treatments that are going to be out there. List them all. The reason I have this ostracized is because in this particular case report that I'm using, and I'm sure that you guys will come up with it, there were certain treatments about certain problems that were part of her case that I excluded, not because they weren't relevant to the case, but because there was so much information. There's so much vast information about this mare that I would not have enough room to fit it in the guidelines by the AEVNT. So I cut out certain things. I used some discerning judgment, and I cut out certain treatments because they were surrounded by certain problems that I did not include in the case report. Again, if you are choosing a case that is of moderate difficulty, if you will, or is not particularly as complicated as other cases, I wouldn't recommend this. But if you're sitting there going, like, I really want to write about this case because I've done all of these things and it would showcase my talents and my knowledge very well, but it's just so dang long, what you can do is with a discerning eye, go through and cut out certain parts of it. So again, in the beginning, start broad, cut out the information and cut out the information that's unnecessary and leave in the stuff that is relevant to the case. When you're writing out your treatments, make sure that you're using generic names of drugs. That is, unless the brand name is particularly relevant to that treatment. So an example is that instead of writing that my patient received Banamine, I wrote that the patient received Flunix and Meglumine. Also, what we need to do is write all of the procedures that are described. And again, this is a place for your knowledge to really be demonstrated. So what you can do with this like knowledge showcasing is to go really in depth with pharmacology, the step-by-step of surgery, which would be the technical procedures that are performed during surgery, the instrumentation that was used. You can go in depth in describing a procedure of a technical skill that you used. The list goes on. You want to consider narrowing this down if needed. I mentioned that before, but this is your time to shine. So don't shy away from, you know, throwing in a little bit of detail there. For example, when I was discussing my colic case, we at Purdue use potassium penicillin and gentamicin as a broad spectrum pre-anesthetic antibiotic combination because the beta-lactam of the potassium penicillin and the gentamicin aminoglycoside combination acts on both gram-negative and gram-positive bacteria. And suddenly I sound brilliant, right? So if you can apply that to your case report, you are going to showcase just how much knowledge you have about your patients. So start at the very beginning, ask yourself what's next and repeat it because it's going to be a day-to-day thing. Some things that I did not write down in this presentation is starting out with like the presentation day and then day 1 of hospitalization, 2, 3, 4. So later in this presentation, you'll see that I've noted that on day 26 of hospitalization, the patient XYZ, that helps a lot with chronologic ordering. What I did for organizing all of my medical records was I read through it all and then started out by writing an outline. So I started out with a signalment and the, presenting physical examination, the diagnostic findings, and then from there, that's really where the bulk of the information is in your case report, and it can get a little confusing. And so from there, what you can do is start making the outline of, this was the treatment applied to this problem, this was the treatment applied to that problem, this was how the treatment then progressed, and then you keep going from there. So that's the progression of the treatment. You are going to detail out how the patient did while hospitalized. So again, the chronological order of how things went. You're checking for a notable change in status. Is your patient improving with treatment? Are there complications that are arising? Have the treatment plans been changed? Do describe the complications or the sequela of the case. So that would then result in management changes, right? So for example, we began at X treatments and there was noted improvements, describe that, but then Y happened and we began Z treatment because A, B, and C popped up. So for example, with our colic case, she underwent colic surgery. She received classic postoperative care, but developed postoperative ileus, and from that point began intensive treatment. There was no change noted, and at that point, the veterinarian elected to go back to surgery for a relaparotomy. So what I wrote was, on day 9 of hospitalization, surgery was performed, revealing irritated but healthy bowels with an adhesion between the jejunal anastomosis stump and omental remnant. Technical difficulties. So at that point, once that relaparotomy had been performed and the adhesion had been reduced, the colic resolved. But of course, there's always complications with that. So then I went on to detail those developments. So for my case, she had a post-op incisional infection. She developed hypertriglyceridemia. She formed jugular vein thrombophlebitis. There was idiopathic ventricular tachycardia that had arisen, and unsurprisingly, 5 other complications that she had that would have been considered minor, and therefore I didn't include it in the case report. So what I wrote to describe the progress of this case was circulating fat accumulated in the liver, causing hepatic lipidosis, of which she never showed clinical signs. Partial intravenous nutrition support was initiated by adding 20 mils per liter of 50% dextrose to plasmolite, creating a 1% solution. 23% calcium gluconate and potassium chloride were continued as additives to compensate for electrolyte losses. I would note that the calcium gluconate and potassium chloride values were reported in an earlier paragraph. So the whole idea here is that in addition to many other sentences detailing the progress, was that a complication arose, unsurprisingly, and this was how we treated it. So the outcome is the conclusion of the clinical case portion of your case report. So did the case report in euthanasia or death? If it did, a necropsy report could be reported if it's available. Happily, if your patient is discharged from the hospital, you could include a brief at-home instructions that were sent home, any pertinent information in any follow-up examinations that you had, as well as a prognosis. And what I would really like for you guys to avoid is writing what I wrote in jest when I was writing a paper about foals. Don't just write foals are hard. Don't make it worse. That's a terrible way to conclude a paper or a case report. Instead, the final paragraph for the case report portion of my document was, the intravenous catheter was removed and the mare was discharged to the referring veterinarian after 25 days of hospitalization. Her prognosis was fair to good, providing no further complications arose. From there, there's a discussion that should occur if you have not already been discussing your involvement in the case. And again, this is very much dependent on what your academy prefers when you're submitting your case report. So if the discussion occurs throughout the case report, this is pertinent. It's just not going to be at the very end of your case report. The discussion is to further showcase your knowledge and to note any advanced skills that you used. This is really a place to emphasize the impact that you made as a technician, and it provides context and relevance to the overall treatment plan and personal nursing strategies. Really just briefly detail any conclusions that have been made in terms of your stance, your opinion, the job description, or the belief that you have regarding that case. And that's literally the end of the paper. Yeah, so here is just a little bit that I had. During the patient's hospitalization, I took on various roles within the veterinary team. For the brevity of this discussion, I will focus on this mare's postoperative monitoring and care. So from there, you notice I went from having an incredibly formal tone to starting to refer to myself as myself, I or me, and the veterinary team as we. I also made the intention of saying there was a lot of aspects that I was involved with, but because this case report is so long, what I'm going to showcase to you is my postoperative monitoring and care, which is why I chose this case report, right? So then I went on to write, due to the extent of her complications, attentive monitoring and rigorous medical intervention was required. We anticipate critical postoperative colics to have complications and deteriorate within 48 to 72 hours. From there, I went on to describe the monitoring and care that I did, as well as using my advanced skills that I needed to showcase. And again, for the 1,000th time, no matter what, you follow the directions and guidelines set forth by your intended VTS Academy. That is paramount. I'm sure that every VTS Academy has an example of a case report in addition to having their guidelines set out before them. That said, though, here are some tips and tricks. Really give yourself enough time. So for all 5 of my case reports that I was required to submit with my application, I took, I would say, 3 months to complete all of them. And this one that we discussed today was by far the most complicated. That allowed for me to spend all the time needed to collect all of the medical information, organize it, and create an outline, and then spend the countless hours that it took to write them all out, and then submit them to my little editing team that I had. And once I got those edits back, I perfected them. And then for this particular case report, I edited it, I sent it back, they gave it back, I edited it, and then I edited it by myself because I was getting kind of, I was feeling guilty about bothering them so many times. Edited it myself, sent it back to them one last time, got the vote of approval, and I was done with it. So really don't wait until a week before your application is due to start these. Your applications committee can tell. We can tell when you've waited until the last minute and that you haven't taken it seriously. So you have to take your cases as seriously as possible. Give yourself as much time as possible to get this done. Not because it's the end of the world, but because you owe it to yourself to have good work. Oh, I wrote go old school on here. When I was originally coming up with this presentation, I realized that I'm getting old enough that it's still like I would write stuff down, and I'm realizing that the kids these days, no offense guys, the kids these days, you guys have tablets and the PDFs and this like a whole different way of cataloging information, but there is so much information. There's the charts, there's the medical records, there's your outline, there's the computer information, there's the books that you need to reference. You have to have room on your table for a glass of water because you still have to take care of yourself. It makes sense to print this stuff out. Again, you have to pay attention to that confidentiality between the client, the patient, and the vet. So please don't go carting this out on public transit and lose it. Keep it in a safe, singular location where you can reference it, and write down, scroll all over it, scratch it out, highlight it, whatever the case is. That is my recommendation. When I go to write my articles now, I use a tablet. I think I'm pretty cool and I'm up to speed, but it still is very overwhelming to have to click back and forth between windows. So consider going old school in this way. Imitation is the finest form of flattery. So if you can imagine imitating your veterinarian when the veterinarian is talking to the veterinarian's colleague, or they're talking to you, and imitate that so that you sound as formal and as professional as they do. If you can sit in on ward rounds, if you can find recorded case reports reported online and imitate that level of formality. If you go and you look up case reports that are published online, that's the level that you want to achieve. So if you can imitate it, then you become it. You're not an imposter by doing that. You are literally following in the footsteps of the people that have come before you. Always write more than needed. You can write pages and pages and pages and then print it out and then sit there with a red marker and scratch out the stuff that you don't like and then go back and edit it. Really avoid that casual language. And above all, give yourself some grace. This is an incredibly daunting task, I recognize. And if you're frustrated, call it what it is. You're frustrated. That doesn't mean that you're stupid or that you're unqualified. It's just a frustrating task. Give yourself a little bit of grace, go get some water, take a walk, pet your dog, play with your kids, and get back to it. I'm going to go ahead and open up for questions. But before you guys unmute, just again, for the hard copies, I'll post it again in the chat. Go to tinyurl.com/1WXYILLS. That will take you to the 3 documents that I've provided for this. And you can email me at mbirtrvt@gmail.com. But if all 100 of you do that, I probably won't be able to find your email because it'll get buried with all of my other Academy information needed. So what I'd like for you guys to do is you can email me, or you can just reach out to me on Facebook, or follow along at the Academy of Equine Veterinary Nursing Technicians. I know that a lot of people are going to be asking questions like, where can I find the recorded recording of this lecture? Either you can, or point your friends to the event page is where it's going to be posted, and it will only be posted for 7 days, and as well as these hard copies. So please do us all a favor, take time in these 7 days to get that taken care of. Okay. I'm going to get out of presentation screen and we can open up that floor. If you guys give me a second also real quick. All right, grandma's using her tablet. What the heck, guys? There we go. Oh my gosh. Thank you for your patience. Okay.
Hey, quiet.
I had a meeting with the AV&T last night. The animals went crazy. Sounds like the phones are too. Let's see. Did anybody post questions in the chat? It looks like we've just got a lot of. Okay. You know what? I don't have any questions in the chat that I can see. So I would love it if you guys, I've got a question from Stephanie. She's raised her hand so politely. That's cute. Stephanie, who's raised her hand, if you want to just unmute, we can go ahead and start the discussion portion.
Hi.
Hi.
I just had a question. So I have gone through the process at least once before, and I'm applying again this year to my specific academy. My question is basically, we all know that like each doctors have their own specific, you do it this way, I do it this way. How do you go about writing and explaining in your case report those like specificalities? Because I've had just for an example, I was told I'm going for my anesthesia and analgesia, and one of the comments, just like as a review on my previous case report, was that pressure controlled ventilation is not a common setting. So I didn't know how to go about from that, which in my practice specifically, we use a lot more pressure than volume controlled. But obviously for certain cases, you would need obviously volume controlled overpressure. But it was confusing to me when I was writing and getting that review that it's not common, but I couldn't understand someone who I'm based out in the East Coast was someone else that's based out in the West Coast or in a different country may use volume control as their natural setting and stuff.
Yeah,
and it's more common for them. So I didn't know how to present that in a case report. Also, if like my anesthesiologist or my veterinarian that's in charge is like, you need to do this, like they're specifically telling me you need to give this sort of stuff.
yeah,
but it may not be common for other practices.
Right, and that's where it's really complicated because we're not veterinarians. We have to follow the veterinarian's discretion. And so how I would write that if it were me, right? And so I would request that you talk to your mentor about that. But what I would do if I were in your position, because I have had veterinarians who perhaps order something that I don't necessarily feel is like an effective treatment, would be per attending veterinarian's orders XYZ. That's a pretty generic way of saying like, this is how it's done. And what you could do is follow that up with, and this is why. But again, your example is pretty specific with the Anesthesia Academy. And I know from some of my colleagues that they're very particular about, justifiably very particular about how certain things are presented or what's accepted. So do check in with your mentor with that example. But what I do is say, as ordered by the veterinarian or something like that. One of the treatments that we did for this colic was the use of lidocaine CRI. And it's not something that's widely accepted. It's a theoretical treatment. And so that's what I said is XYZ lidocaine was started at this time. It can be considered a controversial treatment by some veterinarians, and the attending veterinarian knew that if no change was seen within the first 12 to 24 hours, that it was not effective against the postoperative ileus, if that makes any sense. So I leave it broad for that reason, because in my perspective, I'm an expert, but I'm not a veterinarian, and I don't get to prescribe treatments, and I don't get to have the final say in how certain things are done. All right, Anita Levy, I think you've got your hand up.
Thank you.
Hi, thank you so much for your presentation tonight. This has been wonderful, by the way. My question was, I'm pursuing a VTS in clinical practice, and I'm a little concerned about having so many of the same things come in. and kind of exhausting the number of times I could list the skills given on a spay or a neuter. Could you offer any suggestions about how to not do that?
How to not do that? God, my glib answer is just to say, make sure that you're getting more diverse cases. And I don't know how that really works for the clinical practice setting. If you need to actively seek out different cases that fall in the clinical practice academy's norm. So if you guys see emergencies, or if that's something that's included, if it's more than just a spay or neuter, it could be, you know, just different cases that you would see. Actively pursue those cases to make sure that you are participating in those cases.
Okay.
I think it's very easy for us all to fall into an easy role where, like, of course I'm just going to do lamenesses because that's my job, et cetera, et cetera. But when I was applying to my academy, they have all these different listings. And I think that the AVNT is similar to the clinical practice one because we're technicians working in a clinical practice that see everything. So it's general practice, surgery, medicine, critical care, anesthesia, theorio, all of it. And because I work in surgery, I had to actively go out of my way to find anesthesia cases because Purdue wasn't paying me to do anesthesia on the patients. They were paying me to be the surgery technician. So what I would do is, I think at the time I was working on third shift, I would stay after my third shift and run an anesthesia case with the anesthesia department. So I like received extensive training with anesthesia, then ran several cases so that I could log them and chose one of them as my report. And I don't know if that applies to you, but that would be my recommendation, is to just get out of your comfort zone and find the cases that you want and need, because I could definitely see how it would just be boring, but maybe also they're wanting something a little bit more diverse.
Excellent. Okay. Thank you.
You're quite welcome. Sarah, you're next.
Hi, thank you so much for your presentation.
Oh.
So my question is it's hard to word. You were talking about how earlier where you demonstrate your further knowledge, you know, because you want to be stepping up as a VTS.
Mom, you won.
Cross that
Hold on a
boundary.
second. Sorry, can you repeat that? Sorry.
Absolutely. No, it's okay. So you were talking about earlier in your case reports of how you want to step up and show your knowledge as a preparing, like, you know, to be a VTS, but you don't want to also cross that boundary of seeming like you're being a veterinarian. And I want to do critical care, and that's kind of like a fine line in my brain because these cases are so complex as is.
Yeah.
And I didn't know if you had any advice about that.
Yes. So, God, I could take it 10,000 different ways. It's a great question. The way that I look at a technician is that we're the eyes, the ears, the mouth, we're the advocate for the patient. Like our doctors use us as an extension of their hands, as an extension of their feet, and to some degree, an extension of their mind. So we may not understand, because of education, it's not our job, every single reason that they choose to do a treatment or a procedure, but it is our responsibility to know why. So not so much like the little iota of information and the pharmacologic passing of through the brain barrier to the liver to the whatever, and that's how we save the dog during CPR, right? Instead, it's up for us to anticipate and to interpret why the doctor is doing that. So an example for me, from my perspective, so I'm not like trying to make stuff up about small animals that I haven't touched in 10, 20 years, is to know, we're just going to stick with the lidocaine therapy as an example since we started there. I know that the lidocaine has several different actions, and one of them is to decrease the inflammatory properties when it's given slowly as a constant rate infusion. And so when I set up a constant rate infusion of lidocaine, I know that when I'm giving it to a patient that has a lot of inflammatory properties going, the endotoxins that are released during colic surgery, that the lidocaine is going to act on those inflammatory properties and decrease the inflammation. And thereby decreasing the inflammation is going to increase contractility of the small intestine, which increases overall borborygmi, decreases postoperative ileus. And it's understanding the connection to the connection. It's not so much that I got to choose the lidocaine, it's that my doctor ordered it and now I understand why. And that if my doctor's not ordering it, I can make the recommendation. Does that make sense?
It does. Thank you so much.
You're quite welcome. I know it was like a really weird way of getting there, but if you stop thinking of like, well, I can't because I'm not the vet, but if you're the extension of the vet, you should understand why.
No, that makes perfect sense. Thank you so much.
You're quite welcome. Yeah, so somebody, Cherie Peterson, thank you for this. Worded, said, I think it's how you word it. She listed this in the PowerPoint. This indicates, or the findings are consistent with. It's not up for me to diagnose why the horse is dehydrated, but based on the PCV total protein, I can see that the horse is dehydrated when it's coupled with a physical exam findings. So I can say this horse is dehydrated and it indicates that XYZ, and therefore I can anticipate that this is going to be the next treatment. All right. Does anybody else have any questions? Comments, concerns, complaints, cuss words? Stephanie, yes, ma'am.
Sorry. I guess also because of the more involved cases for these case reports and stuff, trying to figure out exactly what would be pertinent information, what would be, I can cut that out. Like, it's hard to figure out, like, are they going to want this or not want this?
Yeah. So I was thinking about that actually while I was talking, and I thought this would have been a good point to have in the PowerPoint. So I'm really glad you brought this up. If you think about the end goal of your patient, right? Like, what was the biggest problem that they had? Instead of creating a linear narrative, instead what you do is you have this problem that needs to be solved. You can take all the information and surround that problem, right? So if your patient presents with colic symptoms and it's determined that it needs to go to surgery and they've found a strangulating lipoma, there is a big problem there that's going to have a lot of different issues that, as a result, that need to be treated. And so for me, it was easy enough. I was saying that like it was easy at the time. It was not. It was very difficult at the time. But looking back, once I determined the path that I wanted to take, I took the problem and I surrounded it with all of the information and then just started cutting off from there. So I'm trying to think of another example that I have. Totally drawing a blank because I'm kind of on the spot, but what I'm trying to say is that if you envision the end result, which is a description of how to solve this problem that your patient has and how you went about going there, it's almost easier to kind of backtrack or surround that problem with, the treatments or the diagnostics or the procedures that were done to resolve that one big problem. Does that make sense?
That makes sense. Yes.
Okay.
I think I was worried. Like, an additional comment that I had got was like, at one point during the surgery, I had administered like a little extra dose of like propofol. It wasn't like a significant, but I didn't put that in because I had so much other information. And they said, you didn't write this.
Oh, geez.
So I was like,
no, they're very clever over there. That's fair.
Yeah.
So I guess from your angle, coming from anesthesia, and I think that, again, like specifically asking these questions to mentors, or honestly, if you don't have a study group, a study group with the anesthesia crew, you should make one, because these are a lot of questions that people have, and being able to talk it with somebody who understands, which is not me, what you're going through is really important. But because you're going through the anesthesia group, perhaps all of the information that needs to be included needs to be anesthesia related. So I don't know if there's something else that could have been cut instead. That's a very good question. So
Yeah.
yeah, hopefully that helps. Cherie, do you mind unmuting and asking this question or saying what you said here? Because it's good. I just want you to say it.
Yes. My thought was, because I thought you explained this so well in your lecture, and I'm running into the same problem. I have too much information. So what I need to do is limit, like you said, what is the main problem? Yes, all of my dogs and cats have secondary issues like an ear infection, but that had nothing to do with the cat who presented primarily for his blocked urethra. And then we had to go to surgery. We had to keep him in hospital, blah, blah, blah. So even though, yes, as I was writing this out and I included, just to get my information in order, that, yeah, he had an infection and we treated that as well as we were treating him simply because we wanted to get all the pain managed. It ultimately has nothing to do with him being blocked and how we treated him. So I finally cut that out, realizing, yeah, it happened to him, but it doesn't apply to what I'm talking about, what I am trying to, again, showcase that I understood about a blocked tom and how you handle it. You don't go into an ear infection when you're trying to say, this is how I managed my blocked tom and how we really tackled it. So I think that was the idea. Like, yeah, they always come in with extra stuff. But what can you truly disregard, even though it happened to the patient? It's not what you're trying to focus on to show off how awesome you are.
Yeah. Yeah. And even some of the complications that come from the original case presentation might not necessarily be like the one crumb of information that has to be given. So if your patient, like for instance, thrombophlebitis is a common issue that we see with our patients who have undergone like immense amounts of an inflammatory phase in large animal. And so I could have included it if I had room. I didn't have room. It wasn't going to be such an important thing that I needed to include that I included it, if that makes sense. So for some reason, Stephanie, they picked up on you not having propofol at that given moment. Maybe there was something else that would have been more pertinent that would have helped a little bit with your case report. And I do want to just, before we keep going, I really actually want to send a big shout out to those of you who continue to apply to your VTSs, even if you haven't been accepted immediately, because I know that it can be very disappointing to put your heart and soul and very limited time into applying again or a third time or fourth time. Even if you don't get accepted your first time through does not mean that you are not qualified. It means that you get to learn something from it and that there's an opportunity to grow and be better. So if there's anybody else out there that is looking towards applying again after having the original application denied, hats off to you guys. Find as much information and much support as possible, because you're doing good work. And it's a very rewarding thing when you get to that point. I'm going to go to Hannah G. LVT. She has a question in the chat. And she says, how soon before applying for the VTS would you recommend getting the reports done? The academy I'm applying for requires logs or reports to be done within the same year span within 3 years prior to the application. I've got 2 years before I will be eligible for the application. So what I'm reading here is that you're very motivated and you're here on your own accord. Hats off to you. If I'm reading this correctly, the Academy requires that logs and reports be done within the same year span within the 3 years prior to the application. If you've got 2 years before you're eligible for the application, it sounds to me like you get to wait 2 years before writing case reports. If I'm reading what you wrote correctly, if you want to clarify, you can. All right. Does anybody else have any other questions that I might be able to help with? All right. Okay, guys, I am gonna say this old lady is getting on close to her bedtime, so I am gonna bid you all good night and thank you so much for being here. I really do appreciate it. And spread the word. Recording will be available within the next 24 hours or so. I'll have it posted up on the events page.
Thank you very much.
Yeah. Thank you guys for your hard work and